Good morning or good afternoon, depending where you are in this country. Welcome to the webinar. Today's topic is a really exciting one: operational, financial, and clinical strategies to succeed in high-risk model. So this is a great topic, very interesting, very timely, given some new reports that have come out recently. So without any ado, let me introduce you to our panelists. So once again, David Nays, Chief Medical Officer with Innovaccer. I'm the moderator for today. Valinda Rutledge, Chief Corporate Affairs Officer at Upstream. Valinda, welcome to this webinar.
Thank you. Thank you, David. I'm so excited to be able to talk about risk-based contracts. I've been involved in it with over a decade, so very excited about the opportunity.
Looking forward to your insights. And John Supra, Chief Data and Analytics Officer, also from Upstream. John, great to have you here.
Great. Thank you, David, and really looking forward to this conversation and talking about the value-based and risk contracts that we're moving forward with.
And lastly, Brian Silverstein. Dr. Silverstein is the Chief Population Health Officer here at Innovaccer and has a deep history around risk, understanding risk, working with lots of clients, and understanding population health. Brian, great to have you here.
David, so excited to be here and really learned a lot about value-based care delivery from Bob Margolis and Bill Chin of Healthcare Partners when I was working for one of their consulting firms, and that was about 15 years ago. And it's interesting just thinking about how much has changed, yet how far we still have to go.
Exactly right. And as Malcolm Gladwell will say, maybe we're at the tipping point. Let's get into it. So the agenda for today, we've got a big audience. I want to kind of just orient people to talk about the current landscape, what's going on in value-based care, talk a little bit about some of the amazing innovations that are occurring in care delivery, the data-driven tools, because data seems to be the core platform or mechanism to really driving care delivery innovations. And then lastly, how does this all fit together to take on full risk? Take high risk models taking that downside risk, perhaps taking all risk. So without any other ado, let's get into it. So we hear a lot in the news, about controversy, things going on around this. Even in the past month, there's been a number of reports. Valinda, CMS often drives a lot of this. What's going on?
Yeah, so CMS has been able to determine that having patients and Medicare beneficiaries in accountable relationships really make a difference from the cost and quality. So they've been really pushing it. And in fact, by 2030, they want every single Medicare beneficiary in an accountable relationship and partnership with their providers. So what does that mean? I don't know exactly, but 100% in 2030. So as you can see, they've taken the lead over the last decade in terms of moving us to value-based.
I mentioned this idea that maybe we're at a tipping point. We just got through this pandemic and a lot of things started to change, and a lot of interest in doing things differently. Telehealth, since we all had to be home, et cetera. And one of the things that became really transparent in this issue is the issue of health equity. John, help us understand what this is about and how data and new ways of delivering care might help to address this issue.
Yeah, I think that's a really important point and agree with you, David, that throughout the COVID pandemic, we had a lot of questions about access to care, disparities in outcomes related to race and ethnicity. And I think CMS and really the communities and provider communities' goals to understand first and then seek data in order to drive either changes in care or better care. And very recently, over the last months, the Kaiser Foundation, Commonwealth have really called for more data to start to understand where disparities might exist and how we can address them.
Yeah, John, it's really important because we don't often collect data about race, ethnicity, other issues. So we're going to get into this. These become very important things to think about. Brian, you've been doing this a long time. there's been a ton of different models about value-based care experimented both by CMS as well as on the commercial side. You know, we all bundle payments, just an example. Some people say it doesn't work, it does work. So what's going on with this idea of payment models in the industry?
You know, it's really interesting. And this is like many things, the details really matter. And what I think what really happens is people make a very good educated guess. And I think a lot of the folks at CMMI, who really are the ones doing a lot of the pioneering, because by the time the model gets to CMS, it's more finalized, they're making some great choices. And part of this is appreciating that we don't really know what's going to work. So at times we have to experiment and try. And even when a model fails, there oftentimes are learnings from it. And so this is more recognition that this is an iterative process, as opposed to there's one single thing that everybody should be doing.
Yeah, great point. Great point. So everybody's been talking about value-based care since I left medical school, to be honest. It's been a long time. You know, a lot of folks think that they were already in value-based care. And then there's the reality. So let's talk first about perception. Brian, I understand there's been a recent survey done of executives in leading health systems to try to understand where they believe they're at in value-based care. Share a little bit about that report.
Absolutely, David. So this is really interesting. You know, Morning Consult which is a great organization, did a phenomenal survey of providers, executive providers, and asked them, where really is your payment today and where do you see it going in the future? And there's another organization, the HCP LAN, that actually uses payer data, and they have about 80% of the US population reporting to them. So it's, you know, almost 80 different payers, including CMS. So it's the actual data and facts. And what's really fascinating is seeing where people think they are today, and that's the bar chart on the left, and the categories essentially here match to the HCP LAN category 1 through 4, with the top of the bar chart being category 1 and the bottom being 4. And then on the right side, 2025, where do you see it going? So when you ask people today, they say, boy, we have almost no fee for service, and we're pretty much distributed a majority between a link to value and alternative payment models. And where they see it going is a slight shift. Interestingly, not that much movement though in full capitation and population-based payment. What's fascinating though is if you compare this to the reality and the data of what actually is occurring. The data is 40% of payment today is still fee for service, as opposed to the 4% that people are guessing. You know, 7% of it is capitation versus, you know, the 15%. And so just really the disparity there is so significant. And I think what it highlights is that there's a belief that we're actually further along in the journey than what the data actually shows. And certainly part of this could be due to variation that occurs market from market. But one of the great things about the survey, it's pretty comprehensive, covering all different marketplaces. And so really being able to account for what you would think be some of the regional differences.
Yeah, that's a great comment. And, you know, I think one of the things in the 25, 30 years I've been thinking about this is this idea of linking quality is sort of pay for quality, which is like a little tiny bonus if you do certain measure really well, but you're still doing fee for service. And this ACO is often like a little bit of upside only. It's really fee for service, and you're just getting a bonus based on some experimentation around what is a baseline, and maybe you're improving that, maybe not. None of that's really risk, right? It's not risk. So that's what we really want to get into. So I love what you said, the HPLAN. That's something a lot of folks may not be familiar with. It's the Healthcare Payment Learning Action Network. And they recently had a meeting. I know Belinda and John and Brian, I believe you called in, attended that. Why don't you say a little bit about what we learned about the true state of things in terms of where people are in value-based care?
Yeah, so the LAN is a learning action network, and it is a combination of private and public partnership. So CMS and HHS participate in it along with many of the payers. You know, Humana is a part of it, as well as providers. And they look to ways that are built and have obstacles for us to move forward in value-based. So every year they put out a report looking at it from the payer perspective. And not only from a Medicare perspective, they look at Medicaid and they look at the private commercial plans. And what they found this year, they said, oh, it's went up. But as they went through each of these, David and Brian, you know that it only went up 1 or 2% at the most. And so I appreciate people trying to say we're moving forward, but the rate of our transformation, David, is so slow. You can't really say we've made a big difference when it goes from 3.4 to a 4.5. The movement is so slow in response as you look at what's happening to the Medicare Trust Fund, the cost of healthcare going through the roof, it's continue to have access problems. Saying we're only moving the dial by 1% or 0.5% still means to me we are moving way too slow.
Wow, the Health Care Payment Learning Action Network. This is an organization, a collaboration that everybody needs to pay attention to. Clearly, look at this. Almost the vast majority of plans, some states, traditional, make a huge data set really to take a look at this, and a very complicated model around payment models. John, can you kind of walk us through this model, these categories, and help us understand that?
Yeah, I think it's important to understand, and you had mentioned this earlier, David, as well as Belinda, saying that we've moved and worked in value-based care for a long time, but we still see that there is a 40% amounts of payments that really are traditional fee-for-service with no tight link to quality or value. And then another 20% where the link to quality and value may be around hospital payments that have a quality component or a quality reimbursement after the fact. And then moving to categories 3 and 4 is where we really want to talk about the accountable care organizations that now are seeing either upside and downside risk in order to take some risk and change or innovate around care. And really that small percentage, as Belinda said, still in those population-based payments, or sometimes referred to as capitations, where there is significant risk, but significant opportunity for innovation and flexibility as well.
No, that makes a lot of sense. And sorry about jumping the gun on the slide there, but I think it would be great for us to do our own little survey right now for all the audience that's on this webinar. So let's take a poll. And this requires your participation. So how do the majority of your payments in your organization really align around this LAN framework for measurement? I think, what are these different categories of payment models? Where are you at with that? Are you all fee for service as a majority? Is it fee for service with pay for quality, maybe pay for reporting? Is it an advanced payment model built on a fee for service infrastructure like an upside only ACO? Or are you truly taking risk in doing total population management and taking the risk for that population? So let's do that survey and let's have a little discussion about this. Slow movement, a lot of perception that there's been a lot of movement. Reality is not the same as perceptions. How do we sort of get people on board with this and move people forward? John, let's start with you.
Yeah, well, I think as you led off, some reforms in the Medicare Shared Savings Program to really encourage engagement in more organizations to participate. So how does the ease of participation for an organization to come into the value journey and then move along it to take increasing risk and drive more innovation or transformation in their care delivery? So a pathway or journey. And I think the LAN and CMS has recognized that.
Belinda, you agree?
Yeah, I do. And I think there's a couple other aspects I would add to John's comments. First of all, I think we continue to say, should it be carrot or should it be a stick? Should it be incentives or should it be penalties? And I think we've realized it probably has to be a combination of both. We don't naturally, as human beings, like to move into something that we're unfamiliar with. So we do need prodding. It's not just incentives, but we do need a little prodding to make us feel uncomfortable with the status quo. So we definitely need that. people thought MACRA with the MIPS program would actually be the combination of the carrots and the sticks. But it has ended up not being the way that people envisioned. They thought that they potentially could get a 9% incentives, but that was a zero-sum game. The incentives had to be from the penalties, and they made lots of reasons for people to get out of the penalties. They could say uncontrollable circumstances, etc. And so they could get out of the penalty box rather easy. So I think as a nation, we're going to have to decide, are we really serious about that? And we're going to have to put teeth to penalties and give us more incentives, give us more infrastructure to be able to make that move.
That's great. Well, let's take a look and see if the poll is done yet. We can bring up the results and see where our audience is on this particular webinar. Let's bring the poll up. Okay, waiting for the poll.
The poll is up, David, and what you see, it's an interesting poll, kind of matches actually a lot of actually what the LAN actual results are, where 38% are in fee for service, 12% population based. One of the variances, though, the link to quality and value is higher at 40%. APMs and fee for service infrastructure is less. So the group here today I'd view as kind of a realistic group, and especially I think part of it is there was a bit of education we did on the base case, and certainly this group interested in hearing about advanced payments. So I think they're very much clued into this this challenge, and I think that when you kind of elevate the discussion, part of this is a recognition that change at times, and I think I heard this from Belinda, like, why aren't we going faster? Sometimes change is a multi-decade process, and it's just going to take quite some time before the infrastructure is put in place. And I think as we start to talk about what you really need to do to be successful in these advanced models, it's not something you can build overnight. And absolutely agree, by the way, with John and Belinda's and David and your comments that this is something that we there really are some important policy decisions. And if you look actually at even David, where you started, next year, every physician in Medicare is going to take a pay cut. That's going to happen. Barring an act of Congress, which certainly might happen, the conversion factor is down, almost 5%. So everyone's going to take a pay cut. And in addition, the extra incentive payment for participating in the advanced payment models, the 5%, is going to expire. Now, granted, the payments for the prior year performance will still get paid out, but I think we're going to start to see slowly but surely, the water level is rising here.
This is an awesome discussion. And I think for the audience, if you're a little jolted right now, you're starting to think of, what do we do with this, right? So let's get into some of the new innovations that are being leveraged in the industry to really kind of take on risk and move beyond where we have been. So a lot of opportunities to innovate care. We've had these traditional models, right, for 25 years. We know we need to stratify the population, right? Find high risk, low risk, medium risk patients. We know we have to think about care management. We have to manage care, particularly for those high risk patients. And then we also have to coordinate care between members of the team, right? Primary care, specialty care, different organizations. So let's start with this idea of population health. I still remember D. Eddington, University of Michigan, saying, what currently is risk is not what will be risk. There's an issue of rising risk. Those that are low risk become high risk, and you got to watch for that. So I think of that as dynamic risk management. So John, you want to say a little bit about this concept of the dynamic risk management?
I like what you said there about, we've called it the rising risk, or that language of dynamic. I think in those 25 years, we've been good about identifying and building care models around those with the most risk or the most need. What we really need to continue to do is understand that dynamic or fluidly all of the information or data, as we talked about earlier, that's available to us, how do we start to use that in identifying people that may have a change in lifestyle, relating back to some of the health equity or social determinants of health work? We may see behavior changes in how they seek care. And how do we use all of those as signals within all of the noise to say, should we nudge our care team to reach out? And what would that reach out look like? Doesn't maybe need to be a traditional office visit. So this idea of using data in a lot more data sources than we have in the past to understand who should we be outreaching to? What does that outreach look like? And how do we build care models and care teams that may extend well beyond the traditional healthcare or primary care office?
Yeah, gosh, we're never going to get there. Real-time data flows to understand that with traditional claims data, are we?
Well, it's an important place to start, but it's a starting point. We're
Yep.
going to have to bring a lot more dynamic data into the thinking, our modeling, and then the actions of our care teams.
Awesome, awesome. A great point. You got to bring all this data together and make sense of it too. I'd like to Belinda talk about this issue of care coordination. It's all about teamwork, and we've seen a lot of progress in the industry of understanding that primary care is so important and that so much can be done in the ambulatory market, right? You don't have to utilize, brick and mortar facilities to really manage this sort of care. So, we've talked of there's the Oak Streets, the Auroras, the ChinMeds, there's all these primary care groups that have been very successful in moving that puck forward. So where are the specialists in all this? I mean, people need specialty care. So why don't you share a little bit about your learnings there?
Sure. So one of the things that CMS has begun to have lots of conversations about, and in fact, at the recent land, Sarah Fogler, that's in charge of the initiative in terms of integrating specialty care with primary care total cost of care focus models. So putting them together. So as you know, David, we in the past have had episodic models, and it's been kind of uneven whether it's been successful or not. And then we have primary care models that are focused on keeping people out of the hospital. But we know people go into the hospital, even as much as you want to keep them healthy and keep them out, they will go in, and that'll be the highest cost a point of their care once they go in. So we have to figure out how to integrate the two. And they're beginning to ask us as stakeholders, and I would highly recommend all of you that have any ideas to reach out to David and Brian or myself, because we would love to hear from you in terms of integrating specialty care and the specialists with a total cost of care model led by primary care. And there are ways that we can do it, and they're looking at the different ways. But the number one thing that they're saying is we all need data to begin with. When you are looking at total cost of care, you're looking at the amount of hospitalizations that you have, but you have to go within those hospitalizations to say, how much did that hospitalization cost me, and was there a way I can partner with that specialist? So they plan on giving us a lot more data for us with an interfacer's help in terms of analyzing that data to be able to say, what is the true cost of the specialist care that's embedded within the primary care model?
Yeah, it's a really important point. And it's a core concept, I think, to move forward to deliver a true population health workforce is teamwork, right? How do we get teamwork? Brian, care management's always been an important piece, but care managers often act in silo from the physicians, the specialists, primary care, and they worked in silo from other folks. How do we think about this concept of workflow and how technology might support workflow to support teamwork?
David, it's something that I've come to really begin to appreciate more recently is the role of technology and how technology really does have huge impacts on behavior change. It has impacts on everything we do in our life. And the more friction there is, the less likely we are to do it. And the simpler it is, the more likely it is to happen. And when you really, just in thinking about the problem we're trying to solve here, which is how do you succeed in the high risk models, as much as it's to some extent an enigma, it actually isn't. there's a number of organizations that you mentioned earlier, all they do is capitation and risk, or a vast supermajority. So they've built their infrastructure that way. And in doing so, the ability then to understand the patient, segment care, deliver care, it's completely different than what we're doing in most of the traditional fee-for-service health systems. So the real question, I think, today is less, hey, what do we do? It's more, how do you take an existing fee-for-service infrastructure and modify, change, adapt it so that you're able to still allow that vast majority of fee-for-service business to occur, but at the same time, simultaneously, really be able to handle risk-based contracts, which have very different activities and very different outcomes. And that's really the core piece of it, is how do you actually understand at the basic level which patients are in which contract? Because if we expect the frontline caregivers to do things differently, that at the onset is a non-starter. It's not going to work. And then based upon the contracts people are in, then what specific things do we need to do? And how do we make it really easy to do those right things? Some of which will be at the point of care, but a lot of the stuff has to occur outside of the point of care, in patients' homes, as we were discussing earlier, coordination with specialists, all the different points and components of where patients need to access the system.
Yeah, I love your latter point. I often talk about the point of care for a doctor, right? Because we're the patient seeing, or the care manager when they're working around a patient, or the patient. I call it the, the point of life care. So, because they've all got a smartphone, it's a nice way to engage them. My plane's late, so I can take an hour. How do we use that leverage, right, to engage the patient as well within their flow of life, right? So this are really important points. Data and technology, it sounds like, are the key to moving beyond traditional approaches of risk, risk stratification, care management, care coordination. They've all been great ideas, but now we're in a new mode for this, right? So lots of stuff going on here. You mentioned insights at the point of care. And then one of the points is many people are in different EMRs as well. Let's talk a little bit about that. Belinda, have you seen this in the work that you're doing in Upstream, where some docs are in different EMRs, but they got to work together? And how do you think about that?
Yeah, so I'm going to turn it over to John, because he's been working a lot more closer with the physicians regarding EMR. John?
Yeah, great. And I'm going to start a little different place, David, and come back to that question if it's okay. And I want to pick up on what I heard Brian saying, which I very much agree with, this notion of how do we start to look at the care that's delivered in many settings? And I think this really gets at the EMRs, the care delivered within physicians' offices. Most of the EMRs have been designed for that type of work. And it's important, it facilitates both patient care in the traditional settings and the fee-for-service billing process. But I like to think about, as we consider what happens beyond the physicians' offices, the hospitals, into the community, how do we start to integrate the care, the workflows that care coordinators might be doing, that teams within our Upstream model that are pharmacist-led, or that other groups may be engaging in? And I think this brings us back a little bit to the question that you started with around health equity as well. Health equity demands data that we haven't been collecting traditionally in the EHRs. Some systems and practices do reliably, others don't. So I think one of the things that CMS is calling for is just some consistent data, and they've used the new REACH model for realizing health equity in community health as a gateway or pathway to say those ACO participants should be collecting this data. And not only should they be collecting this data, but what's the opportunity to take a look at social determinants of health data? Another great example as well of a place where some health systems, some community groups have been doing screenings. Those screenings haven't been consistent. So under the REACH model, REACH participants are being required to start social determinants of health screening. CMS has looked at 3 different models to choose from. And I think more importantly, there are groups already thinking about standardization of data to collect health equity, race, ethnicity, other conditions, and the responses of those social determinants of health screenings in a consistent way. using the interoperability standards. And some people may be interested, a group program called Sync for Social Data, sort of starting, and so many of the group here may be aware of the conference on hunger, nutrition, and health that the White House held. All of these are coming together to say, we need to be looking at the whole person in care. And when you're taking risk, how do you come alongside good health and food support, transportation and housing? So we've talked about social determinants, we've talked about data, we've talked about coordination of care. I really think this next level of innovation is calling on us to bring all of those together. Data is going to be critical, data that can interoperate between our traditional healthcare providers and community organizations, and platforms and technologies, like Brian was saying, that allow us to be aware of what's going on with the patients and community we're caring for and know how and when to outreach to them. That's been a real differentiator in these successful primary care models.
No, this is really awesome. I just want to, there's so much going on in this slide. I just want to pull it together. The EMRs were built during the HITECH Act to really, in essence, help to support billing, because we had paper charts, right? So they became billing machines, and they've been trying to move beyond that. There needs to be a way to give insights about the whole spectrum, right? All the different doctors and all the EMRs, all the different care managers, the other people delivering care, and connect all these folks for really good workflows so that they're all working together as a team. And lastly, this very important area you've talked about is the social determinants of health. That word gets thrown around a lot, and a lot of people don't realize fully what it means. You mentioned some of it: housing, transportation. Break it down a little bit, like give an example of a social context and how you would address that at Upstream.
Yeah, that's great. So one of the things, and I think both Belinda and I mentioned, part of the Upstream model is to engage clinical pharmacists and in deep assessments, looking at medications, opportunities around medications, social assessments. So could you do programs like Food is Medicine? Could you do programs where the ACO partners with local food banks or other programs to have food delivered or to be made available, and really switch or adding to that coordination of care, where food is viewed as part of the health and well-being of the patient, that the ACO, in partnership with primary care and all the providers, are taking risk and responsibility for. I think there's similar work going on in housing or transportation, and behavioral health as well. So how do we look at all of the care that a patient, their family may need, the social supports they have? We may learn when we're interacting with a patient that their daughter moved away recently, and that's really taken effect on their ability to have transportation to receive health care. The Upstream model looks at engaging in that way so that we're aware of that. We collect that structured data, and then we make use of it to recognize that dynamic, or what we talked about earlier, the rising risk as well. So I think those are some of the ways that we need to be able to do assessments, make them available, that the Sync for Social Needs is making sure that groups like Upstream can interact with the EHRs, and the physicians and their practices can see that information, and vice versa. So that's the sort of dynamic future that I think data as well as the care model can play.
Wow, there's so much going on here, and people worry about, geez, if I address issues around non-traditional clinicals, housing and like I'll go broke, right? So you need this data and analytics to try to figure out how you're going to manage from a financial perspective as well. Let's figure out like what's going on with our audience. Let's go back and take another poll and see where they're at in leveraging some of these approaches. So for those of you in the audience, a quick poll: what innovations are your organization taking to really address high-risk models today, going into next year? Are you investing in analytic capabilities? Are you developing customized care management programs? Are you improving health IT infrastructure, leveraging new technology, addressing the issue of multiple data sources? Are you exploring new partnerships to better manage risk? Are there others? Are there none of the above? You're just sticking with what works today? Let's take a look at that. So let me ask this question, Belinda. You've been doing this a long time. Do you see change next year in 2023 in the industry?
I think 2023 is too early for us to see change. I think we're still trying to get over the effects of the pandemic. Certainly with a decrease in the stock market, you're having a lot of the funds, investment funds that hospitals had available in terms of investing in capital is now limited. I think 2023 is going to be a difficult year. I see us starting to have some of those changes in 2024. But what systems can do in 2023 is start working on the competencies, start thinking ahead. Don't wait until 2024, in which we'll see some of the relief from the financial pressures that we're seeing now. Get ready for 2024 and use 2023 as an opportunity for you to begin to develop those core competencies that you need.
Brian, that really fits into conversations you and I have had. You know, I think you view this as a work in progress that is going to take quite some time. Why don't we take up the poll results and take a look at where our audience is? And then, Brian, I would love your comments on how that fits in with this, you know, long-term project we have in this country of moving to value-based care.
Absolutely, David. And while we're pulling up the poll results, you know, something that both John and Belinda, you know, highlighted is really when you think about moving to these high risk models and being successful in them, it really is this recognition that the EHR is a critical piece of the fee-for-service infrastructure and digital information, but a vast majority of EHRs are not necessarily set up from a workflow and other component points of view to be optimized for the high-risk models. And that really is the challenge, because when you look at essentially all the organizations that do high risk, all of them, of course, have an EHR, but it's very rare that their providers are primarily logging into the EHR. Almost all of them have built systems where they're designed to be able to manage the patients in those models, and specifically with those social determinants of health. Because when you think about what's really going to make a difference when you're getting the full capitated dollar, then transportation matters. You know, who's the caregivers matters. All of these things turn out to be much bigger factors than actually the care that you're delivering. However, if you're in a fee-for-service model, all of those things are not reimbursed, and those are just if you provide those are just expenses. So these really are fundamentally two different business and clinical models that have different system level support. Now, turning now to the poll results, we see that those are up. Very interesting results. And the poll allowed people to select multiple items. And so investing in analytics, we've got about 70% doing that. Customized care management, 46%. Improving IT infrastructure, 65%. Exploring new partnerships, 58%. Others are 8%. And so everyone, I think, is doing lots of different things. And what this highlights is, if there was one thing to do that would really make a difference to everybody, we'd all be doing it. This is very much an individual journey, and really it's about understanding your market and your providers and your contracts and your technology. And so there's all of these components that really have to be considered. And I think the poll results accurately represent that people are very wisely making choices about what things are going to matter for them in their marketplaces.
So Belinda, I just really want to capture what Belinda was saying before. Maybe 2024 will see movement. Do these poll results support your notion?
Yes, because the number one, 70% was investing in analytic capabilities. So people want to be able to develop those competencies to take a look at the data that they're getting. The data that they're getting, as you said, for the most part, are claims or EMR, and it's just has not been effective. And they want to develop more deeper capabilities.
John, I know you're fighting to talk about this because care, you know, you and I have talked about this at Upstream. You know, you are so excited about the work you're doing. Can you say a little bit about, you know, how that fits into if people are actually adopting those things, how that will really put them forward to start addressing these issues?
Yeah, absolutely. I want to pull a thread I think Brian started forward a little bit as well, as he was talking about the EHR and its infrastructure to deliver fee-for-service care. I like to think about and talk about when we're looking at either coordinated care, as Brian said, many of the teams are in multiple systems or have built their own. I really think about it as customer relationship management or patient relationship management, where touching the patient, knowing about what they need, and being in communication is as important as the care being delivered. And how do we start to think about those working together? And I think that opportunity to not only engage in taking responsibility through risk-based contracts for care outside of the office, but even in being involved in new and novel partnerships. We talked a little bit earlier about specialty care and bundles as a traditional service-based way. I think another piece that we can think about is how can ACOs partner with those food or transportation organizations and under flexibility be able to hold each other to risk. If they do a good job in delivering food to their patients, can they be part of that risk program? And I think there's a lot of opportunity there. And I think this really gets to your question here, David, of when we start to think about risk-based infrastructure, I think Brian really teed it up as we're going to have to deliver care. The EHR is going to be a primary source of care delivery, but the systems, the infrastructure around that are going to look a little bit more like relationship management. They're going to look a little bit more like tied to big data, machine learning systems that can actually know what's going on a little more quickly and actually offer, and I like the language of a nudge or a task for a care team member, a family member to outreach to that patient or that family. And we're going to have to understand cost a lot better. So in the fee-for-service model, the providers or ACOs typically rendered the services, the bills were dropped, and that was part of the relationship. And a true cost of care or total cost of care, all of the expenses need to be understood and how they play into both what is working, what it's costing, what that risk relationship looks like. And I think that's true of the traditional care, it's true of specialty care, hospitalizations, and of opportunities to provide some of these supports through social determinants as well.
And that makes a lot of sense. You know, let's check in with our audience again, because there's so much here as people are investing in this technology and new ways of doing things. To Valinda's point, maybe in 2024, we're going to start seeing movement. Let's take another poll and see what they're actually thinking about doing with these investments. So for everybody on the line, if you could take this poll, are you using automated workflows to connect your care teams? Are you using this dynamic, more real-time patient stratification and knowing that high risk can become low risk can become medium risk, that risk changes over time? Are you thinking about reporting and analytics to really manage those contracts, to be able to know what's going on in the environment, primary care, specialty, post-acute, social determinants of care where you're making investments? You got to track this stuff or else you'll go broke. And then are you thinking about real-time analysis to continue to innovate, right? Keep learning. So while we're taking that poll, a couple questions from our audience. So coming back to you, John, because you're very passionate about this issue of leveraging the social determinants of health. How can providers really capture and use that data to improve care management? How should they be thinking about it?
Yeah, that's a great question. So a number of EHRs are already including some social determinants of health assessments. Both Epic and Cerner have some standard, and many of the other EHRs do. So I think the first piece is how best does the provider, their practice team, think about doing that assessment, be it on an annual basis or any regular basis to capture that information. And if it's not available yet in their EHR, there are some paper-based tools. You know, the data person doesn't love to say that, but many of the models do have paper-based tools to start to get a baseline. And that really goes back to those questions of health equity. And then many of the care management systems have standard assessments as well. And as I'd mentioned previously in the CMS ACO REACH model, they've identified 3 different standard assessments. So I think the first is what's available to you? How do you standardize in your practice? And then that gives you some insight to how do you understand what those social determinants of health needs are in your patient population, and allow you and your teams to develop some strategies, usually in concert or in partnership with local community benefit organizations or others that may be able to help you as the provider address those social determinants of health needs.
Great comments. I think it's going to be very helpful for people to think about that as we start leveraging the social determinants of health. Let's bring the poll results up, and I'm a little bit blind to them. So Brian, if you could let me know when you see them.
Sure, absolutely. And while we're bringing the poll results up, just to kind of comment on what John was saying there, and you know, it's interesting even just thinking about, hey, sometimes you might need to use paper, and also to Belinda's earlier comment about, hey, really analytics is where you want to invest. And I think that, you know, there's no right or wrong as much as this is just a recognition of sure, you could do paper, but how much scale, and that might be a good way to start for a proof of concept, and this gets to that whole issue of you really want to be in value contracts, you have to have electronic infrastructure to make the right choice, the easy choice, and collect this social determinant data. And another question came in just to tie that together, and then tie the interventions to the social determinant data, because really that's where you're going to get the outcomes. And it's that recognition that if you offer everything to everybody, even in a risk-based contract model, everyone gets food, everyone gets transportation, everyone gets everything, that becomes unaffordable. So it really is that ability to be able to, at scale, segment out which patients have which needs and then deliver them in a seamless way. And those things will make such a difference in the healthcare utilization. They're not going to be showing up in the ED. They're not going to have all the admissions. They're not going to get bounced from specialist to specialist. And the amount of improvement you could have in patients' lives, it's remarkable, but you have to have the contracts in place and the infrastructure in place. So it is almost like this progressive chicken and egg piece, and certainly you have to start somewhere. So along those lines, our poll results are in, and what did people say here? And again, we're talking about which strategies can organizations improve the care delivery models. Automated workflows for care delivery teams came in at 28%, dynamic patient stratification at 44%, reporting and analytics dashboard, that was the number one at 61%, real-time data analysis to identify opportunities was at 44%. And so certainly a wide mix there though, but the reporting and analytics was clearly at the top there, because I think that's almost like a foundational piece to be able to do some of the other things.
You know, I've seen Belinda shaking her head up and down throughout your passionate explanation of sort of not only the results, but you're thinking about all the things that need to come together. Belinda, your thoughts about it?
Yeah, I'm surprised that the real-time data analysis to identify opportunities was so low, because I put those side by side in terms of reporting the analytics dashboard. I want my dashboard to almost give me real time. So I'm kind of surprised that one was 60% and the other one was 44%. So that kind of surprised me, but nothing else. They were all sort of in line with what I thought. John?
Yeah, I want to build on that, Belinda. I wasn't surprised that the dashboards was so high, because I think in the healthcare space broadly, it's the question of, could you give me this report? Could you give me this dashboard? But I want to challenge the audience in this group to, I believe that we've got to be tying these together. It's the information that may show up in a dashboard and people are hungry for it, but it's really, how do we start to use machine learning and data science to say, how does that do the dynamic stratification? And how does it build or power those automated workflows? So I think this represents fairly where we are, but I think we've got to strive, as we've talked about in many places, to take that information that may show up in those dashboards, but really push it into the workflows so that our care team members know what they need to do next to care best for the patients that we're responsible for.
This has been great. You know, these polls, to learn from the audience, are just so awesome. They really tee up a great thinking and conversation. Speaking of conversation, Belinda, I love this statement. Why don't you share a little bit about your perception of what you think about the concepts?
So Upstream was founded by Fergus Hoban, and our focus is in terms of moving upstream in your care so that you have independence, and that we see that when people are not healthy, they have a state of dependence, and nobody wants to be dependent. They want whatever comorbidities they may want to, that they have, they want to optimize their life. So this is our mission statement: health is a state of independence. Now, if you go to the next slide. And as John will go through this, but as John had previously said, what we basically do is we embed care teams, particularly pharmacists, in partnership with primary care practices to identify particularly the chronic disease patients. A lot of patients that have chronic diseases, they'll be on 10 to 12 medications, David. It's just, and their life is just centered around taking those medications. So what we do is we come in with the Upstream model to change how that care is delivered to the patient so the patient becomes more independent. So John, I'll turn that over to you with the 3 circles.
Yeah, great. Thanks, Belinda. And really, the clinical circle or at the top, our work at Upstream, as Belinda said, is about bringing a pharmacist-led care team alongside primary care to support the medication management specifically, but the social determinants supports, and to coordinate the care to the greatest extent possible within primary care and beyond. And that's really at the core. So we're a clinical or care model-led organization. We know, and we've talked about the investments that one needs to be successful in risk and technology, infrastructure. And we also know many of the current models, as we talked about at the beginning, are driven by shared savings or payments that are very far out. So we've really built a model that we refer to as the Upstream Gap Q that allows the providers, the physicians, to be paid for the work they're doing now with high quality, and connecting that to the patient care where we're balancing the risk or working with them. So we reward quality through our gap care payments. And as we've talked about throughout this, data, technology, workflows are critical. So I like to really think about the technology as accelerating the work of our care teams and facilitating or enabling our unique Gap Q payment model.
Yeah, I really like this idea that there's clinical innovations that need to be done, technology, platform, bringing in the data, being able to understand how things are changing, where you make your investments, what's working, what's not. Question that's still out there: what's the correlation between an organization's willingness to move to a higher percentage of their revenue in risk contracts and its investment in a digital infrastructure? How should people be thinking about that? Let's start out with you, John.
I think they're pretty tightly coupled. And again, I'm going to use digital infrastructure to be pretty broad. The tools to understand the total cost of care, to do that claims analytics that traditionally physicians, provider organizations haven't. And then moving quickly to what we talked about today about thinking about the digital infrastructure is a methodology for engagement or a tool or facilitating that engagement with patients well beyond the walls of traditional healthcare settings.
No, yeah, this is a great transition. I love the name of your organization, Upstream, right? Because it's all about not where the doctor's seeing the patient, it's moving upstream where all the causes of health, adversity occur, right? Going up to think about how do people eat? What's their environment? Are they safe? What supports do they have on a social side? These are the things that can really move us to higher quality care, higher quality outcomes in the population, and much, much, much lower cost. So I love this idea of let's move upstream instead of, I think David Nash, our friend Brian, often says, instead of mopping up the floor downstream. So that's a key thing. And Brian, the name of the organization, Innovaccer, we're talking a lot about financial management and clinical management. And there's a technology framework to really do this sort of innovation and care model. What is the name Innovaccer? Where did that come from?
Sure. So I think the name really is about accelerating innovation. And if you think about it, and this is, I think, an important concept to appreciate, is that time really matters. And the longer that we wait to do something, the worse it is for patients, the worse it is for everybody. And so it's this whole notion of how can you actually accelerate the innovation and get things to move faster? And the core concept being one of, rather than saying everyone needs to switch systems, everyone needs to be on the same thing, how can we actually have a data platform that will connect with everyone's current existing systems so you could do it faster and easier, but get everybody the same information? You know, if you think about it, in the early days of, smartphones, nothing worked, nothing connected. You'd have one thing on, your calendar, nothing synced, and it was awful. Now it's almost like a given that the information you have in one becomes one in another. And while in the consumer world, that's how it works, in the healthcare world, that isn't how it works. And really, that's what Innovaccer does, is it enables that so that you could have these programs that could actually make a difference in the value-based care delivery contracts. And, that was the earlier question someone asked, that John commented on and agree with, your willingness to move to higher risk contracts and your investment in the digital infrastructure. You somewhat get into this chicken and an egg where, boy, if I don't have the infrastructure, I can't succeed in the contracts. But if I don't have the contracts, it doesn't make sense to invest in the infrastructure. I'd suggest actually there's a pathway here, that there's a lot of things you could do with value infrastructure that works in a volume world. Identification of gaps in care, annual wellness visits, looking at transitions of care management, advanced care planning, being able to better manage referrals. All of this will bring revenue in and support that infrastructure that you really need to do all the things that are going to matter for patients in more advanced capitated contracts.
That's great. And this slide here really demonstrates sort of the power of teamwork between a technology organization like Innovaccer to create that platform, and teamwork with a group of people that are really thinking about innovating care and learning about how to continue to improve care with Upstream. So we will make a copy of these slides available to everybody and continue to learn about both organizations. We'll make that available, and obviously a link so you can learn more as well. What I would like for each of you to do, because you're each such experts and you've had great model around this over the years, let's just give in one line sort of what recommendation would you give our audience for the things they need to think about coming out of this webinar as they move forward? Belinda, let's start with you.
Yeah, as I said, is to really focus the year 2023 on getting the development of your core competencies in analyzing the data. Get data analytic capabilities within your company and within your organization. That is going to be key, because I think 2024 is going to be a very, very busy year for all of us in value-based models.
Brian, your thoughts?
I think that I'd encourage us to, rather than think about this as a discrete thing, either it's a yes or a no, we're doing it or not, to more think about this as this is a measured movement that's occurring very slowly, but will happen faster in some markets. So rather than view it as I'm all in or not all in, it's more about what steps can you take today that are actually going to make a difference in your current financial situation and lay the groundwork to really be able to take better care of patients in the future.
Awesome. John, wrap this up for the audience as we close.
Well, I think Brian gave a lot more details of what was on my mind, and the notion that this is a journey. Value-based care is a journey, both in how we care for people and how we take our current provider fee-for-service models towards value. And that doing something today that's going to help our patients and put us down that pathway is important. So take that first step and understand it's a journey.
Yeah, absolutely. Hey, listen, I want to thank each of you, Belinda, John, Brian, for coming today, sharing your insights, talking about what's going on in the industry, and really talking about this key concept of a partnership, not just partnership between primary care, specialty care, hospitals, policymakers, but a partnership between technology and innovation, care innovation. So I think that it sounds like the future. We look forward to continuing to work with Upstream. For all of you in the audience, thank you so much for participating today. We hope you learned things. And as I mentioned, we will follow up. Happy to provide more information. I think the folks at Upstream would be thrilled to hear from you, and certainly those of us at Innovation would be thrilled as well. We're all looking for new partnerships to really improve the health and wellness of our country. Once again, thank you very much. With this, we're ending the webinar for today. Thank you very much for attending.